While treating patients with septic shock, we often face a few questions regarding vasopressors. When to start vasopressors? What should be the right first choice agent? When shall we start the second vasopressor agent if it is required? What should be the second agent? What shall be our right target for vasopressor infusion? And finally, when shall we stop vasopressor infusion? Coming to the first question, when shall we start vasopressor infusion? In patients with septic shock, when the diastolic blood pressure is very low or patient's diastolic shock index, which is nothing but a ratio of heart rate and diastolic blood pressure, if the diastolic shock index is more than 2.3, in both these cases, vasopressor infusion should be initiated along with the fluid. If it is not so, vasopressor infusion should be initiated in that case also as early as possible, maybe after 1 to 2 liters of fluid. Now, what should be the first line agent? There is a clear evidence now that, and there is a consensus across the spectrum that for adult septic shock patient, norepinephrine should be the first line agent, though no clinical trial has ever shown a superiority of one agent over another. But in terms of arrhythmia genesis, norepinephrine is shown to be less arrhythmogenic compared to dopamine in SOAP2 trial. What should be the second agent? The consensus is now for vasopressin or adrenaline. There is now some evidence growing for angiotensin II as an alternative agent. When shall we start the second agent? As of now, there is no definitive evidence when to start the second agent, but we can take some clue from the VAST trial where it has been shown that when the vasopressin infusion is started beyond a norepinephrine dose of more than 14 microgram per minute, mortality increases. So based on this data, we can say that we should start the vasopressin infusion or any other second line agent when the norepinephrine dose is rapidly escalating to beyond 14 microgram per minute. What should be the right target? That's a big question. I think there is now some consensus that initial MAP target should be around 60 to 65 millimeter of mercury. If the patient's perfusion improves with this MAP target, then we should continue with the same initial MAP target. But in case patient's perfusion is not maintained with this MAP target, and there is no scope for further fluid boluses or any inotropic infusion, maybe we can go ahead with a vasopressor challenge with a increase in the MAP from 60 to 65 to maybe around 80 to 85 millimeter of mercury, and look for the improvement in the tissue perfusion. Our ultimate aim is a normal tissue perfusion. If the tissue perfusion improves with the revised MAP target, maybe we can revise our MAP target to 80 to 85 for further resuscitation measures. Now, when shall we stop the vasopressors? We need to stop vasopressors for two indications. First of all, if the shock is reversed, vasopressor infusion should be gradually tapered off and stopped. Now, which one should be stopped first, the first line agent or second line agent? There is no clear consensus. It is up to the clinician to decide whether to discontinue norepinephrine infusion first or to discontinue the epinephrine or vasopressor infusion, which was started later. Second type reason for stopping the vasopressor infusion is if there is an evidence of adverse effects. Profound vasospasm leading to digital ischemia or arrhythmia If possible, in such cases, we should switch over from one vasopressor to another. So this is maybe a simple strategy for treating the patients with vasopressors in septic shock.